Welcome to the Baker Institute. This event is sponsored by the Baker Institute Student Forum, the Baker Institute for Public Policy, and Rice University. I wanted to first thank all of the staff and also call your attention to the last page of the program. We have a list of other people to thank. And then I also want to welcome especially high school students who are here. And some folks have been having trouble finding the bathroom, so I will let you know. There are bathrooms out front. There is also a men's bathroom around the corner back here. I wrote an M on this side. Well, okay. The men's, I suppose, is on this side, and women's is on this side. We have a couple of changes in the program. Filling in for Rodney Goody will be Jeffrey Campbell, also from St. Hope Foundation. And James Dixon will not be able to make it. He has to attend a funeral today. All I just wanted to say was a few words on the motivation for this event. I don't know if any of you remember so long ago when we had a presidential election and people were watching debates, and there was actually a vice presidential debate. I don't know if anyone but me watched it. But Gwen Ifill was the moderator, and there was a specific question she asked, and I'll just read what she asked. I will talk to you about healthcare, Mr. Vice President. You have 2 minutes. But in particular, I want you to talk about AIDS, and not about AIDS in China or Africa, but AIDS right here in this country, where Black women between the ages of 25 and 44 are 13 times more likely to die of the disease than their counterparts. The question, what should the government's role be in helping to end the growth of this epidemic? Cheney's response, he kind of talks generally about things. He mentions the $15 billion effort for AIDS in Africa. And then he says, here in the United States, we've made significant progress. I have not heard these numbers with respect to African American women. I was not aware that they're an epidemic here, because we have made progress in terms of the overall rate of AIDS infection. Then she turns it over to Senator Edwards from my home state of North Carolina. And his response didn't make me particularly proud of him as a senator. The first thing he says, well, first, with respect to what's happening in Africa and Russia and other places around the world, ... He goes on to talk about the healthcare system, and that's about it. And then Gwen says, okay, we'll move on. Because obviously neither of these two people who are running to be vice president of the United States knew anything about this problem in respect to African Americans. So that's the motivation for today. The first panel, hopefully get everyone sort of up to speed on the problem itself. And I'd like to welcome Dr. Vivian Ho, who is a fellow here at the Baker Institute, and also has an appointment over at the School of Medicine, UT, right? Okay, thank you.
Yeah, the first panel members, please come up and join me up here on the stage. From what I understand, we have 35 minutes. Thank you for joining us today. We have an excellent group of panelists, and I'm just going to read their names and their organizations and their short biographies about these individuals, but I just wanted to get to allowing them the chance to speak as much as possible, so I'll be brief. Today we have with us Mr. Alan Barrett, who is with the Wall Talk Project. He is the Wall Talk Project Coordinator for the AIDS Foundation of Houston. Jeffrey Campbell, St. Hope Foundation. Ms. Barbara Joseph, Positive Efforts. Dr. Stanley Lewis, also from the St. Hope Foundation. Ms. Amanda Turner from Families Under Urban and Social Attack, and Ms. Sharonda White, Houston NAACP Health Director. Dr. Lewis, since you are a physician, maybe we could start with you. And could you give us an idea of the type of patients that you're seeing here in Houston? What is the patient population that we're dealing with in terms of AIDS?
Great, thank you, Vivian. I'm probably one of the luckiest physicians in all of Houston when it comes to being able to treat persons with HIV, because I get the opportunity to see them in several different settings. St. Hope Foundation is a group of three medical clinics. There is one in Conroe, one in Stafford, and one in Bel Air. And we service persons primarily indigent, primarily African American, and persons who are more or less disenfranchised in general. Most of our patients are uninsured, and their care is provided, or should I say funded, by the Ryan White Care Act. Our clinic is also unique in some respects because it does reflect sort of the leading edge of the epidemic with respect to the gender situation. About 60% of the patients that attend to the St. Hope clinics are female. So so that's one set of patients that I've been fortunate to take care of. I've also taken care of patients in the private setting at the University of Texas Medical School General Medicine Clinic, where again the changing face of the epidemic is clear, but in this clinic patients do have insurance. There are more white and more male and more gay patients in that clinic. And then finally, I've had the opportunity to work at Thomas Street Clinic, which is the Harris County Hospital District's primary clinic for taking care of outpatient HIV. And that clinic actually reflects more, it's certainly starting to more reflect the leading edge with more minorities, African American and Hispanic. And this clinic is, again, one of the largest clinics in the world, freestanding clinics in the world for treatment of HIV. And you're also starting to see that demographic of patients underinsured, indigent, and really, when you think about it from just the medical standpoint, undercared for in a global sense. So it's not just the HIV per se, but it really does extend down beyond into the socioeconomic disenfranchisement that oftentimes leave these patients undercared for, not only for HIV disease, but for other health concerns.
Thank you. Ms. Joseph and Ms. Turner, if I could, I know all the panels are involved in AIDS education in some form, but if I could get you to speak a little bit about AIDS education and what you focus on when you're trying to reach these populations, and any of the panelists feel free to jump in at any point.
Okay, well, my name is, of course, Barbara Joseph, and I'm two things. I'm a person that's lived with HIV for 21 years. I have to think about it sometimes. For 21 years, and I'm still doing very well. Never been ill. And I have started my own nonprofit organization about 4 years ago, and I did that specifically because I was trying to reach African American women. In the very early days when I first was infected, and I was infected in 1984 from a blood transfusion. Since that time, I found out that there were many African American women not even realizing that they could get infected. They just weren't listening. They didn't feel that they were gay and they were in a situation where they would get infected with this virus. However, nowadays it's very apparent that more and more African American women, young women, are getting this disease. Not only young ones, but also the older women now are being infected because they're not educated, and that's basically what it is. Well, lack of education is the reason why we are getting so many new infections. So that my focus in my agency is on women. I have a sister class that we do that help women to understand where they really come from and how important they are, and those types of things. Self-esteem, build their self-esteem, and then give them the knowledge that they need to know about protecting themselves. I have outreach services as well as case management, and I'm trying to remember everything, and trying to invent testing into all those roles. But I work with many agencies in the Houston area, because in order for us to get this information out, we need to all collaborate and work together.
Ms. Turner?
Good morning. My name is Amanda Turner, and just one correction, I'm not the Executive Director of Family Center Urban and Social Attack. I am the Program Coordinator for HIV Prevention Services since 1998. And our main focus at our agency is prevention, targeting the African American community, heterosexuals, male and female. We have a high concentration on African American females is because they are the #1 population that are getting infected. And what our services, we do for the past year now, provide the rapid testing, the 20 minutes test where we can give a person their results in 20 minutes. And our testing component, what we do is we go out and test during non-traditional settings. Non-traditional settings is getting the people that you don't get on an everyday basis. We go out in the evenings, in the late evenings, and at night. We set up where we do provide testing because those are the population. That is the target group that you would not get, just say, at this type of forum, or you would get at a health fair, or you would get during a event. This type of the population are the ones that you would see on the corner drinking a beer or just perform a sex act. So we go out and we focus on the population that you don't see on an everyday, not a 9-to-5 person. Our population are the population that we see at 7 o'clock in the evening. And that's why we focus on that population.
Could I get you to expand? Do you ever have trouble getting people to agree to testing in non-traditional settings? How do you get them to
Yes,
to
we
do the
do,
tests?
because one thing about the 20 minutes, a person has to be ready to get their results. Before we say, okay, let's get tested, we have to counsel and talk. Some do not want to get it in 20 minutes. Some do. So it's really client readiness. If the client is ready to get tested. We did a testing event the other day in a location in the late evening. We tested 12 people. One particular person did not want it, but we had to constantly coach him because he was about to leave. To get, because he didn't want to know his results, but he did get his results. So it's really client readiness. It's not only client readiness, it's also the counselor readiness. Because giving a person their results in 20 minutes, you got to look at both sides of it.
Yeah, thank you. Mr. Barrett, we had a chance to speak a little bit before we started the conference this morning, and you work with the prison population. Could you talk about the particular challenges of helping with this population in AIDS?
Sure. My name is Alan Barrett. I'm with AIDS Foundation Houston, project coordinator for Project Wall Talk. Just a little bit about what that is it's a prison peer education program. What we do is we go into prisons across the state of Texas. Each unit has a selected group of about 15 or 20 offenders. We spend 40 hours with them, training them on all sorts of topics, not just HIV. That's the primary focus, but they learn about hepatitis, tuberculosis, Staphylococcus aureus, diabetes, which is also a big deal in prison. And after they spend that week with us, they become peer educators because it is our belief that they will listen to each other a lot easier than they will listen to people in authority. And we have great success. We have the program on 66 units across the state. So I'm spread pretty thin, and I've been to every podunk town there is in Texas, because that's where prisons are. Just a little bit about our results is I was telling Dr. Vivian, what's your last name?
Ho.
Okay, earlier, that we did a study of 5 prisons that had this program and 5 that did not. On the 5 that did have the program, they saw an increase of over 300% in testing. On that unit. So it is a results program. We see tools for making tattoos that are being left out on purpose to be confiscated because they're finding out that they can catch hepatitis C through tattooing. All right, so we're seeing all these positive results of this program. You know, the deal about the prison population is that everybody, it's kind of the forgotten population, if you would. People do not believe that prisons have anything to do with them. Just let me give you an example that 102 offenders with HIV were released in June of this year. They all are released to Harris County at first, okay? There was a study done in South Carolina on prisoners who were HIV positive, and within 6 days of their release, there was a large percentage of these guys that had unprotected sex with their partners, knowing that they had HIV. Okay, so our job is not only to educate them while they're in there, but to educate them on what to do when they get out. Okay, and it's not always about them. It's about, okay, you think your girlfriend's been waiting for 15 years for you out there. You need to go out there and ask questions. I basically tell them that having sex today is like getting a job. Here's your application, fill it out, I'll check your references and get back with you. You got to keep it really simple with these guys, and let them know that they're not the only one that's, they're not the big danger. The danger can be beyond the gate, so we educate them on what to do outside the gate. One of the other things that I just always like to throw this in, we found that we had over 90,000 instances of out of the classroom educational moments when our evaluation was done. That means they caught you on the rec yard, they caught you in the chat line and said, hey man, don't you teach that HIV class? Can I get this way? Okay, so they're getting all these questions to them. They run into a lot of problems like, well, you teach that class, you got that lick. Okay, there's all that sort of stuff that goes on in prison too, because simply being a peer educator can put you in a certain category, and in prison, remember that being gay or viewed as weak or anything like that is dangerous. So they have to fight all those battles, but these guys stick it out and they do a really good job, and I'm always real proud of them. And let me just tell you about, as far as the numbers, in TDCJ there's about 150,000 prisoners in the state of Texas. 2,408 of them are HIV positive, okay? And as far as the African American total, it's 1,500. Okay, so you just take that number and do the math yourself, but 2,408 positive, okay, 1,500 are African Americans, so the problem within the black community is also in prison. Thank you.
Thank you, Mr. Barrett. Ms. Wright, could you tell us about the challenges that NAACP is facing in terms of dealing with the AIDS population, how to address this problem in the Houston area?
Okay. Yes, I was listening to Barbara Joseph and Miss Amanda Turner as far as when you were saying the challenges of when individuals are going out and testing. And unfortunately, a lot of times what we have to do is provide incentives. A lot of people say, well, my gosh, you would think that an individual would want to, be tested and know their results. Unfortunately, no, that's not always the case. So we have decided, we've been looking at everything, and at times what we do at special events or throughout the community is we provide Walmart cards to our population, just $10 gift certificates, which is a lot, but it brings in that community, it brings the clients to us. And most of the time the challenge that we face is just getting the client there to test. As far as providing education, the challenge is still, I would say, the client themselves being in denial, not knowing that this, or not wanting to accept that it is a problem. When we're going out into the community, sometimes we see individuals, we see women or teenagers who are pregnant, and we're trying to pass out condoms to them. They might be pregnant themselves and have 2 or 3 little kids behind them, and they're saying, I don't need that, there's nothing, I'm not having sex. And you're going, you're not having sex, but you're pregnant. Okay, so we're still, it continues to be a challenge in getting the message across. I don't know, I think we become angry, our colleagues, we have become angry. We're like, what do we need to do? And we're still looking off into that. What is it that we can do to help our community? We are clueless. We keep saying, okay, we're looking at everything, but the bottom line is it's the behavior, and more than anything, that's the hardest thing to change, is someone's behavior. Some of the individuals out there in the community are more educated than we are. So they know, they just have not practiced. Unfortunately, even some of my colleagues that I know, we don't practice what we preach. So I think we have to begin on our side as well before we can go out there and do what we need to do. But every day is a challenge for us. And I'm so excited to see all these young faces out here. And I hope that you are protecting yourselves. That's very, very important because you are at greater risk. We're also finding out here lately, we have a lot of nursing homes who have begun calling us for us to come out and educate them. So that's very exciting to us because they are aware now that yes, the older generation is continuing to have sex. So we're excited about that challenge as well.
Thank you. Mr. Campbell, one of the other things we're supposed to address in this session is looking at social and monetary costs of AIDS. Could you talk a little bit about do you have enough resources? You know, what are some of the challenges in terms of the St. Home Foundation in terms of coming up with resources to fight AIDS and treat patients? And
The answer to your question is, are there enough resources? The answer to that is no. There are, when we start looking at the HIV and AIDS epidemic, there are several different arenas that need to be addressed in regards to funding. First and foremost, it is prevention, and that is education that is placed in the community to help individuals to make better choices by either not becoming positive or to even help a positive person not to infect someone else. So you have prevention monies that are needed, and then you also have care monies that are needed in order to provide care for individuals who are HIV positive and who are in the AIDS stages of the virus. So St. Hope itself, we are funded by Ryan White, and several of the Ryan White funding streams. We're also funded by the Texas Department of Health and Human Services, and we're also funded to do testing and education by the City of Houston's Health Department, and those funds come from the Centers of Disease Control. And if you would just allow me to tag on to something that Amanda said earlier. We were talking about the difficulty in getting individuals to test. One of the areas that I work in primarily is education and prevention with African American men who have sex with men. And we use the term men who have sex with men because many men who have sex with men do not like to be labeled gay, bisexual, same gender loving. So clinically and socially, we use the term MSM. One of the struggles in getting African American men who have sex with men to get tested, particularly in public venues, is surrounded by the stigma of homosexuality and being gay in the Black community, as well as the stigma of being HIV positive in the African American community, in the African American gay community. So there are some difficulties in getting individuals to test in those venues. We've tested in clubs. There are several events that are held here in the city of Houston throughout the year that have a huge population of African American men who have sex with men, and it is often very difficult to get our brothers to get tested and find out their status, and then to be proactive about getting into treatment programs for that. But back to your initial question, I don't think there's ever enough money. There's so much work to do, and when we start looking at numbers, Alan has given some numbers about the prison system, but in the Black community itself, we are at the top of the radar in regards to newly infected individuals, or the rate of diagnosis. We are far, far above every other ethnic and racial background in our communities with our men as well as with our women. And so to provide treatment and prevention and care, it takes a lot of money. And I do have some of those numbers. That would include medication for an individual who is HIV positive, particularly a person who is just starting on a medical regime, that it's about $2,000 a month. And that's just for HIV meds. That doesn't include medication for hypertension or for diabetes or any other chronic issues that a person may have. It's about $2,000 a month. It can move upwards to over $3,000 as the virus and disease progresses. When we talk about treating patients, and Dr. Lewis can probably help me on this, I believe that it's costing our Ron White funds about $2,500 to $3,000 annually just for doctor's visits. That does not include lab work.
And actually, I don't charge that much.
No, he doesn't charge that much.
But it does take quite a bit in terms of laboratory and X-ray, and certainly if there's any periods of time during the year that a person is ill. So those sort of unscheduled visits, if you will, that can really cause the healthcare cost to skyrocket. It is a huge problem, and then it's hugely underfunded.
And I think the other thing, just as I close with that piece, is there are other costs that are involved that we might not think about, because many of the individuals across the nation who are infected, who are HIV positive, they are at poverty level. They may not have transportation to get to the doctor. So when we start talking about funds for metro bus passes and taxi cab rides and things like that, those are additional funds that have nothing to do with medication or lab work. So yes, I think every agency that does the work is tremendously underfunded.
Actually, if we could just step back a minute, because Mark had asked me to do this before. Could maybe Ms. Joseph, could you tell us sort of what are the actual specifics when you educate people on how you get AIDS?
Specifics.
Yeah, just give us, for example, when you. Just briefly.
First of all, I always have to, and I tell people this all the time, I have to do a disclaimer because I'm kind of like raunchy. I kind of give them the real 211. I'm trying. I give them the real 211. I think it's too often we get very politically correct and we miss the whole book. So when I'm usually talking to people, I try to give them, I tell them what's real. I tell them what's really happening out there, how we're getting it, how we're going around and we're sleeping with this person or that person. Whether it's a man or a female, it doesn't matter. Somebody tells you you look good, well, you're trying to get that person, so of course you're going to do whatever it takes to get them. And we're not thinking that this could also get us infected with an STD or HIV. It's not that much fun to live with HIV, quite honestly, because then you have the risk of having to tell people that you are positive, I would hope, immediately. However, I know a lot of people don't do that too. They just kind of keep it a secret, but I actually give them the real facts, how they actually get it. And it's all about having sex, Most people don't know the ways that you can get it. They think that you can touch a doorknob and get it. Well, that won't happen. You're not going to get it from a doorknob. You're not going to get it from a toilet seat, but you are going to get it from vaginal secretion and pre-com, and you're going to get it from blood, and you're not going to get it from urine. So a lot of people don't even know this, the very basics of it. And once they find out the very basics, then you have an opportunity to protect yourself a little bit better. But I kind of give them the whole scenario. I teach women all of those things that they need to know about keeping that man and making him happy at the same time. I put condoms on dildos with my mouth to let people know that you can do this without him knowing it. The ladies that walk on, the ladies of the evening. I've done programs in the middle of the night where I go out at 2 o'clock in the morning or at 10 o'clock at night and stay until 2 and 3 o'clock in the morning, because that's where it's a whole new world out there at that time of night. You don't see them because you're at home in your bed. But let me just tell you, it's busy at 2 o'clock in the morning. And a lot of the times, that's when people have lost all those inhibitions, okay? That's a bad phone. So, did I answer your question?
Yeah, thank you. And
Vivian.
Oh, please.
All right, I just wanted to sort of maybe dovetail on what Barbara just said. I do believe that the epidemic, particularly in the African American community, is somewhat of a conspiracy, if you will, and that conspiracy is of silence. We don't really talk sort of straight talk like Barbara does, and I call Barbara's talk really sort of the R-rated version of prevention education. But within the African American community, there is a huge stigma attached to this disease, as it is probably in all communities. But it's obviously impacting our community more because of the disparity and the overrepresentation of African Americans in terms of just our total numbers of people, only making up about 12% of America, but then making up 60% of new cases. And this idea that Mabel's boy died of leukemia has just really got to stop. Mabel's boy died of HIV, and if you don't tell Mabel's other kids about HIV, guess what? They're going to die of too. And I think that when we stop stop being politically correct and get real about this and face this threat head on, then that's when we will really start making some progress on both the prevention and the treatment exercise. In my opportunities to interact with people with HIV or people that are at risk for HIV, I really find two things, and I'll point this specifically to the young people that are in the room as well as to young people in general. It appears to me, and I think one of the other panelists has also mentioned it already, that some folks actually do have the information. It's really, I think it was you said, they actually know more about it than I do sometimes in terms of all these things that are going on that are really risky behaviors and can result in transmission of the virus. But with the younger group, it does appear that it's not ignorance to the game, but really an indifference to its rules. So once you already know how this happens, but then you go ahead and still take those chances. And getting over that is part of just maturing and growing up. But unfortunately, different from perhaps when I was a teenager and I thought I knew everything. Only difference was I did know everything. But today's teenagers, they don't know everything. No, but really, seriously, it is the stakes are so much different now. I mean, and so this idea, we can't just say, oh, well, they're teenagers, they're going to do what they want to do. We still do have a very, very serious obligation to find the right words or find the right TV show or find the right rap song or whatever it's going to take to get this message across, and so that it not only comes across as real, as it can affect me, it's not somebody else's problem, I'm not invincible when it comes to HIV. Mm-hmm. That's really got to happen now. And with the last thing I would say is about the patients that I take care of, those already infected with HIV, is there's a huge intersection between HIV and mental illness. And when I say mental illness, that's another sort of taboo phrase and a taboo area of healthcare within the African American community. No one wants to really talk about I'm depressed, or I hear voices, or I have serious mood swings, and I'm sure that especially within the prison population, there's a huge problem with bipolar disorder, and that these problems are not race specific. They do happen to African Americans, and this is not something where you just pull yourself up by your bootstraps, or you're just going to get over it, or whatnot. But that there are actual therapies if you can accept the diagnosis and are willing to take the medications that can actually improve that mental outlook. And when I think about patients who are dealing with HIV, it does appear that they really fall into two groups. There's the group that finds out that they have HIV, and then they go get the care, they come to their visits, they take their medications, and they do very, very well. And then there's another group that no matter what you do, it's regimen after regimen, they've got resistant virus, they missing their visits, they're in and out of jail, they're having all of these other difficulties. And I keep asking myself, what is the determining factor? I mean, what is the core thing that makes one group take one pathway and one group take the other pathway? And I have come to this conclusion that I do not know is complete, but it does seem to really get at the core, is that the group that goes this way has something to live for, and the group that goes this way thinks that they don't. Mm-hmm. And if someone is in your office and you see that they don't think they have something to live for, first of all, as a physician, depression should cross your mind as a potential diagnosis, but even more so, you realize that the problem is much, much more than just the HIV. It's really finding a way to get that person back connected to the idea that life is worth living. Because a person who doesn't think life is worth living doesn't mind spreading this disease to someone else. A person that doesn't think that life is worth living is obviously not going to take his own medications and puts himself at risk for developing resistant virus. And a person that doesn't think that their life is really worth living is so disconnected from not just the American dream, but the human ideal that life is valuable. So we really do have to, it's inextricably bound to this idea of HIV, is this idea of our mental health is playing a huge role in, and until we address that issue concurrent with the HIV, we won't turn the HIV around.
Mr. Campbell, did you want to follow up?
Well, yes, thank you. Dovetailing on the question that Barbara answered in regards to education, I think it is very important for those of us who are prevention educators to understand, and I think many of us do it well, particularly those who are on the panel, is that there has to be a unique way of presenting the information dependent upon the audience. We can't present it we can't put it in a box and take that box to every group, because it might not necessarily and won't be received. And so I think it's important for us to realize that and to tailor our presentations according to the audience that's going to receive the information. And I think that takes us well down the road in regards to that, getting the prevention and education information out.
Thank you. We actually have time for one or two questions. I mean, I have lots of questions, but I wanted to give the opportunity for the audience if you wanted to ask any questions to our panelists. Yes, please.
Alan Barrett, I'm sorry, I realized I left my little thing.
I just want to ask where you get funded.
Oh, it is a HRSA grant. It's a minority initiative money from the government.
And a second question relating to that is, how stable is that?
Okay, right on the spot. We actually lost funding. Our grant goes through the end of this year, and we had a 3-year grant, but this program started with a 4-page document on HIV back in 1997, and it is now a 223-page curriculum that I'm willing to share with anybody who'd like it. And it's gone a long way. And so this grant that we got was based on a peer education grant that served all sorts of peers, not just prison. We were the one prison focused. And it ends at the end of this month. But AIDS Foundation Houston has stepped up to the plate and has committed some of its own funding to keep this program going until we can secure other funding, because they planted the seed and then we got others involved. Montrose Counseling Center, I worked for them for a while. They were involved in the prison program, and they still are. They do case management, because we don't do case management at the level that like Montrose Counseling Center does, so we have to be willing to send people to where they can get the help. So that's what we do. But AIDS Foundation Houston is committed to the program. That's what I can say. It's not going to go away. And I'm right now going across all those 66 prisons, making sure these offenders and the TDCJ understands that we are committed to it and we're going to keep going. So yeah, it was a huge loss. When you guys were talking about funding earlier, I had to think back. I got to hear this HIV guru a couple months ago at UTMB. And she had this slide that showed that $87 billion was given for the war in Iraq and $4 billion was given for AIDS research. There's your funding.
Is there another question?
Hello.
Hello.
Hello. Someone mentioned that AIDS is the primary disease among African American women. I want to know, does anyone have the numbers or the statistics of how AIDS affects teenagers or young adults?
Well, I just know that people under the age of 25 are accounting for more than 50% of all new infections. Is that correct? And there's really, under 25. And I'll just say that that's what you guys were talking about, education. That's the population that we really need to focus on a lot, is the young community. I'll just jump out here and say that at the age of 23, I was infected with HIV. It's 18 years ago this very month, and when we are young, we see we're basically bulletproof. And I think as a society that we have to open the doors that allow us to talk to the young people, because nobody talked to me. I was in the military, and I literally walked out of the closet as a gay man, and my very first gay male partner knew he had it and infected me. Okay, so it's like, but nobody got to me with education. And today, I can't go into any school in the city of Houston and talk about condoms. I can't go in there with my fake penis or anything like that. But when the homecoming queen comes up pregnant with syphilis, then they want to talk to us. You know what I mean? But y'all can go talk to the juvenile delinquents, all those little people of color who are in trouble. Y'all can talk to them. But when the homecoming queen comes up pregnant with syphilis, then they want to talk to us. So it's like, we have to be willing to break down these barriers. And it's like Jeffrey said, it's the people up here that are trying to knock those walls down so that we can protect you guys. Because like she said, I don't want anybody to have to live with this disease, okay? Because it is a job, and I thank you for talking about mental health. That is certainly a struggle with people with HIV, and it's, it's up to us. I'm sorry, I can go off on some education.
Yeah, we all can.
We don't have
We got some passion up here at this panel.
we don't have the
That's right.
exact numbers of young people, how many here in Houston, but we all know young people between the ages of 13 and 24 are the greatest risk of acquiring HIV and AIDS. But also it does not say about the other STDs. That they also are getting. We do have a program, just going back to what he was saying earlier, going into the school. We go into the schools, we get funded through the City of Houston Department of Health and Human Services to go into the HISD's various school and teach HIV education. We cannot pass out condoms, we cannot present no dildo, but we can show slides of the STDs. This is what gonorrhea look like, this is how syphilis look like. But just going back to the young people, really it starts at the home. The parents are the ones that need to be educated. Parents saying, no, my child is not having sex. Communication, it starts at home first. And what we also try to do is to try to educate the parents, because the parents are the first one that need to be educated about HIV and AIDS and all of the other STDs. Then we work with the kids. But we go into the different schools and we educate the kids on HIV and AIDS and other STDs. We talk about their community, you talk about communication skills, risk assessments, and that way they do a pre and post test because we want to see what did they learn. And a lot of kids in the schools, they already know. And going back to the language, we got the core elements, but we tailor to fit the kids. Their language, what they talk is totally different with us. So we have to go and talk to our peer educator. What do you say for this? You don't call it a penis, what do you call it? What do you call oral sex? They can relate to their language better than just the political, what's written down on paper, what we have to present to them. So that is how we tailor that, as to focus on the kids. We can change it around, but this is how they say it.
And let me just add
Just one
more
last
thing.
comment, yeah.
Okay. And the other thing is that I've gone into high-risk areas and talked to children and youth, actually. They weren't children. And they're right here in Houston. And the problem of it is that 500 children were in this gym that I had to talk to. I could not come out and talk to them politically correct because they didn't hear me. They blocked me out. So I turned on the music and got down jiggy with it so they could understand where I was coming from. And in this particular school, there were 500 kids in this room, and out of that 500 kids, there were about 20 young ladies that had 4 to 6 children already, ages 14 to 18. Then no one is talking to them. So if we can't get to the parents and let the parents understand that we've got to talk, if you can't talk to your child, then we can talk to your child, and we can do it where they'll understand what's going on, because we've got to stop it some kind of way.
Well, I'd like to thank all the panelists, and I wish we had more time, but we need to give time to the other panels coming up. But thank you for an excellent introduction to start the morning off.
Thank you.
Thank you all again. We welcome Holly Hurd from Rice University to moderate the second panel. Also, everyone from the first panel, please stay here. The whole kind of point of this is to have communication between the panels, so please stay here if you can to bounce back and forth with the upcoming panels. Thanks.
That's me. I want to welcome everybody for the second panel. The title of the second panel is Why is AIDS a Problem in the Black Community? So what I'd like to do is I will first start off by introducing the members of the panel. And I've got a few set questions that I hope will spark dialogue among the panelists. And then we hopefully will again have time for questions at the end. So I'd like to introduce our panel. First I want to make sure I go in the proper order. So excuse me as I move around a bit. First we've got Miss Judith Lahai-Momoh, who is with the organization Saving Lives Through Alternative Options, and they are advocates for the reductions of health disparities among communities of color. Is that accurate? Okay. And then we have Dr. Faith Foreman, who is with the Health and Human Performance Department at the University of Houston. And then again, Alan Barrett, thank you. I want to make sure I know where I'm at, who we spoke with before, who's the Wall Talk Project Coordinator. And then, thank you, Dr. B. Drake Williams with the WAM Foundation, which is the Windsor AIDS Ministry. And then finally, Dr. Bronwyn Lichtenstein from the University of Alabama with the Institute of Rural Health Research. So thank you everybody for attending today. So I actually wanted to piggyback on some of the comments made by the previous panel, again as part of this goal of sparking dialogue. And what I thought was an interesting point, make sure I got this right, was Dr. Stanley Lewis's comment or idea about the conspiracy of silence, which I thought was a very interesting term. So the idea of, in a sense, a conspiracy or a neglect of information. So I wanted to present to the panelists, anybody who wanted to step in, this question of why are African Americans unwilling to talk about the disease, and are they less willing to talk about the disease than other groups? If anybody wanted to step in for that.
Well, do you want to say? Okay, let me go ahead. I am coming from probably a unique situation because I have been in the U.S. for 30 years now and originally from Africa. And I do travel to the continent very often on the lines of HIV. So I'm able to pick up what is going on in Africa and what is going on here and be able to see, because there is so much going on the continent that people don't know. We're not communicating at all, but we have the same problems and need to really be in sync, because you can learn a lot from Africa that you can really use here, and that's what I found out. Because here we are so structured on how we can deliver our messages. In Africa, they do theirs as they go, and they pick up from all angles. So I think we should really be in dialogue with them. But what I also want to focus on is our agency is currently involved in research, because a lot of times African American organizations are not really conducting research, and we still have this Tuskegee syndrome that we don't want to be part of. But if you are not studied, nobody's going to be able to give you what you really need, because they are going to base it on whoever they have studied. The medication that they can use for me has been tested on somebody else. So is it going to really be effective for me? So these are some of the issues that we have to start looking at as blacks in the community, that we need to let people come into our homes and study us and then we can let them better, prepare what the best remedies are for us. So that's one thing that I really want to appeal onto our communities to start doing. When it comes to, I did make some little papers that, you're welcome to share later on. And this is, okay. So usually I say when you finish, then you pass it on. So anyway, I'm going to do that. And this is based on the African and the immigrant communities really here in Houston. We work with all the communities. Like I say, currently we are conducting a study in the African American community on videotape-based studies. If it's more effective than when you really talk to a live person. And this is the second time that it is really replicated. The first time it was done in Atlanta, and it's an NIH-funded project. So we are right now conducting it. This is the third year that we're doing it in the African American community. One thing with the African community that we have to know of, because this is why is AIDS a problem in the Black community, which incorporates the African and or the Black diaspora. In the African community, or even in the American community, polygamy. But when you look at polygamy in our community and the African community, you are born thinking that you have to have 2-3 wives, and you are legally able to do that. So when the African moves here in the US, you don't have that legal right, because here by law you have to have 1 wife, 1 man, 1 wife. But our brothers are not really practicing that, because they know it's illegal, but the women understand that, and it is something that is understood, so they are still doing it. Instead of having 1 wife legally, some of them even have 3 wives. So they sleep like here 3 days, go to the other place, sleep 3 days, and all the women know about it. It's not everyone who is doing it, but quite a few of them are doing it. So that's one thing that we have to look at. So if one person has HIV, then it's going to spread amongst, the other wives or
So you would suggest that perhaps there's a cultural norm, if not of having multiple wives, which we can't necessarily do here in the U.S., but at least multiple sex partners. That's maybe another way in which it may translate.
Definitely.
Okay.
Definitely.
Would anybody else like to jump in on this idea? Again, the idea of stigma, the idea of being unwilling to talk, or the conspiracy of silence.
Well, one of the things that I would like to say is that I kind of like what Barbara said. We want to just keep it real and keep it simple. And one of them would be just about talking about sex in general. I mean, I think that's just a basic there. So when you look at the African American community and just having the dialogue about sex, we don't talk about it. And so when you add another layer to it of HIV and AIDS, then it becomes another problem. And so you have sex that we want to talk about, so we stop there. And then the other layer is HIV and AIDS. So I think that's part of the biggest problem there, just being able to put it on the table and to actually talk about it.
Yeah, I just want to say that, I hear that the African American population is not talking about it, but I think that at some levels they are, because when I was working at Montrose Counseling Center a couple of years back, the African American churches reached out to us, and they asked us to come out and do HIV education to their congregations, because they saw that this was a problem in their community. And we went out to several churches and did HIV education. And I, speak publicly for a living, and I'm not usually nervous, but when I was in God's house with my fake penis, I was a little nervous. All right, but what I say about that is that they stepped up to the plate, and not only did they ask us to speak to their general congregation, but they asked us to gear a class towards their teens and even their younger than teens. So we had 3 educators going to each church to talk. So I think that there are people talking out there, but it's just a matter of continuing to talk and hope that people listen. I have a nephew, and I'll just tell this quick story about sometimes people don't listen. I have a young nephew who got a full scholarship to college a couple of years ago, and he was young and handsome and pretty boy, football player, all that stuff, had the looks, he had all that stuff going on. I thought, well, he's in danger. He's going off to college, the girls and maybe the boys will see him, and, this will happen. And so, good old gay Uncle Al gave him a wad of cash, because that's what gay uncles do, and a box of condoms, and said, all I'd like for you to do is come back with the piece of paper that goes up on the wall. That's it. Well, my nephew is in his junior year of college, and he is on his second child with his second girlfriend. And I tease him. I say, the only good thing about that is that you now made our family officially African American because the second girlfriend is black. So, but other than that, I have to say, these kids don't always listen, but you got to be willing to talk. And I say that the black community is talking, but we just need to keep talking.
Can I add to that? I really kind of want to speak from the perspective of the African American female in terms of what Dr. Lewis mentioned as a conspiracy and us not talking. I think one of the things that I find with women in relationships is that we don't necessarily talk to our partners. And I teach, it's kind of my viewpoint, that if you can't talk about it, it's surprising to me that you can show it to somebody else, but you can't talk about it. You know what I mean by showing it? Mm-hmm. It's amazing to me when women can't look at their own vulva, but they can show their vulva to someone else. That's striking to me. And so I educate through what one of my organizations tries to do is to begin with girls and to teach girls, because I believe that firmly it's in the socialization and how we socialize girls from the African American woman's perspective about their body, about the fact that it's one body that they have to take care of it, that they are in charge of it. Nobody else is in charge of it. And before you have any type of sexual relationship with a partner, you must be able to discuss that. It has to be done in an egalitarian, honest, and responsible way of doing that. So I really believe that the conspiracy of silence is not only just in the community, but I think this conspiracy of silence is also within our homes and within our own relationships, from the vantage point that we will have intimate relationships with a partner and not discuss that. I think, and the time to discuss that as a sex educator, which is what I am, is not when you're having sex. The time to discuss that is before you have sex. So I always tell people, not on the first night that you decide that this is what you're going to do. The first date really needs to be a getting to know you date with the lights on. To have that conversation and say, look, if this is where we're going with this, then we need to have a conversation. And so that's really what I try to impart to young women, is that you have to first be empowered to be able to first know your own body, know what it looks like normally, and be able to touch it, look at, be really comfortable with it before you can really share it with someone else. And that goes back to what the first panel talked about, and that is, Dr. Lewis mentioned the two groups. The people that seem to not have anything to live for, and so they don't mind going out and, but it's not, I don't believe it's from malice. I think it's a behavioral thing. It's not, they don't do that with malice and forethought, that they don't have anything to live for. It comes from how they've been socialized and what has happened to them in their social environment, such that they don't know that they have something to live for. So they're not going out purposely. I mean, we had that. I mean, all of us, many of us know each other. So we all had that in the very beginning. I know Barbara from years when I used to be a clinical director with Planned Parenthood. So we all know that initially when the virus first came out, some people were angry and they went out on purpose and they did that, but that was very few people. The average person is going out, they do know that they have it, so you can say there's some malice, but it's really not. It's because people don't talk. We're socialized not to talk to each other about sex, because for some reason sex is some big taboo, but we all do it. So to me, it's just, as a sex educator, if I can't impart anything else to you, is that really, if you can't talk about sex, you shouldn't be doing it. You really shouldn't be doing it. So,
Thank you very much. And finally, Dr. Lichtenstein, perhaps you can...
I was wondering
you would like to step in on that.
I want to back up a bit and explain who I am, and obviously I'm not from Houston, and I'm not even from the United States. I've been living in Alabama for the last 12 years, and when the topic of silence around HIV/AIDS really goes to the heart of why I do HIV and AIDS as a researcher, and I'm at the University of Alabama, and I do AIDS research. That's what I do. When I first came to Alabama, I went to an AIDS symposium in Montgomery, which is the main city there, and I watched an epidemiologist talk about AIDS in Alabama. And just to let you know what the epidemic looks like, in Alabama, as part of the Black Belt states or region, and there are, I think, about 7 of them, and they all have the same statistics. African Americans make up 26% of the population, and they make up something like 75% of those who are getting infected. And I watched this epidemiologist talk about AIDS in the state of Alabama, and he spoke about it in terms of women becoming infected, not African American women, just women. And the graph that he presented was a graph that had stages like this. White women way down here, hardly infected. White men somewhere up here, somewhat infected, but only about a third of the total. Then you had black women, and their numbers were going up. But way up here was black men. And in that entire symposium, which went on for about 3 days, nobody talked about black men. So that became my job. And the conspiracy of silence was around this particular population, which I gathered was a disposable population for public health workers. And I don't think it's any accident that Tuskegee is in the state of Alabama, and that there are certain things you can't talk about in Alabama. And HIV/AIDS is one of them. And the silence around HIV/AIDS, and I hear a lot of what's spoken about here in terms of one's personal behaviour. I don't do that. I look at social structural issues. I look at things like historical issues. Tuskegee was a phenomenon. It was a huge phenomenon. It has a huge aftermath that has everything to do with silence. Why is it that African Americans in the Black Belt, and this is largely rural, and we don't think of the epidemic being in the rural areas, but it is, and it's large, and it's growing, and it is growing among women, no doubt, but 2/3 of them are men. And what are the connections between Tuskegee, this thing keeps going on off, and now with the HIV/AIDS epidemic? Well, the numbers are almost the same. The numbers of STIs in the African American community back then are the same now in terms of HIV/AIDS. But we can't talk about those things. And white Alabama didn't come to terms with this problem. The fact that African American men were those who were most affected right from the very beginning in our Black Belt state, and I suspect in others as well. Nobody knew that, so I produced a paper, and they had to come to terms with that. They're sort of coming to terms with that, but not really. Still, white Alabama will not give money, and the reason I asked that question of you is because we have no money for anything. And it's not only do we not have money for anything, but the little bit of money that we do have is now gone. So there's no money for prevention. So you talk about a conspiracy, and I don't want to go on for too long, but there's a historical conspiracy. And whites are as much implicated as blacks, but I look at the social structural factors of why people become infected, and there's a huge silence around that. So we tend to focus on just personal behaviour. It's never just that. There are all these social structural issues going on, and I could talk about those till the cows come home. I've got lots of papers here if anybody wants to have a look at those, which I can distribute. But I don't want to take up more than my fair share. So
well, actually, I think that's a perfect segue to my next question, which I think I should then pose to you, which is the question of segregation. And if a communicable disease like AIDS is introduced into a segregated community, which African Americans are, how will that disease propagate? And this would be a way to kind of bring in the issue of structural factors and segregation. I'm sorry. Am I on? There you go. Thank you. So if you can...
Repeat that question.
Well, the question is, if you introduce a communicable disease to a segregated community, in a sense a closed community,
right,
how will that disease propagate then? And how will the impact of segregation impact the propagation of that disease?
Right. Well, segregation has everything to do with it because you've got a homophilous situation in terms of having sex. You only have sex. If you are African American, then you have sex with an African American. You don't have sex with whites. So it doesn't get spread to whites, but it sort of becomes pooled both geographically and racially within that population. In terms of prevention, if I could just make one point, when these infections do become pooled, geographically and racially in a certain population, one of the best ways to get to prevention for HIV is to treat STIs. And there are usually high levels of STIs in these communities. And the one way to get at it in a very meaningful way is to treat STIs and to have programs where we actually go out and test people and treat people, and that will prevent HIV to quite a significant extent. So treat those. These communities have huge rates of STIs. But do people know about that and to know about their role in transmission, HIV transmission? And I don't think that is well known. That's part of the conspiracy of silence too.
Okay. Thank you. Would anybody else like to speak on that?
Let me just say, in terms of how the communicable disease is propagated in a segregated society, I can give you an example on a college campus, which would be another example of segregated society, okay, where I am and have been. People commit the crimes that are available to you. Does that make sense? If I can rob a bank, that's what I do. If I can do insider trading, that's what I do, okay? But it's still a crime, okay? So oftentimes people have relationships, they date, they, just as this person has mentioned, the people that are in their network, and it's about networks. And most of us who worked in HIV, we know about social networks, and we know how that, how disease is transmitted. And when it's closed and when, people don't go outside of that, then, you continue to have that problem, and people may continue to pass the virus on, and different strains of the virus, and it just kind of builds on that way. And if there's no intervention, no prevention coming in from the outside, and it is a community that's seen as disposable, or a community where, for example, on a college campus where I'm at a state university, and sometimes the administrators try to legislate what goes on a campus. For example, they shut down, and I can speak specifically, where I am, you being able to provide condoms on campus, where we know 13 to 24-year-olds are the largest growing subgroup who are becoming infected with HIV, but yet the campus would tell you you can't give out those condoms on campus. But we also don't offer any HIV 101, so that condoms are not necessarily, are not needed. So I think you either do one or you do the other. And so that's how it can be propagated through a segregated community, and a college campus is a very good example, and that's where we're seeing higher rates of HIV as well.
That's very interesting.
These are very educated people.
Right, that's very interesting.
The demographic is very different. Even here at Rice, we could.
That's very true. That's very true. Kind of a situation where you have a segregated community where their education and their access to resources is going to be limited, and if you don't provide it, then it kind of grows.
Yes, I can talk about the immigrant population too. When you talk about sexual mixing, and a lot of time people don't even know, because if you look at maybe the African or Caribbean communities here, and you think that, oh God, they are so far away, I don't deal with them. Africa is just 6 hours away. If you're coming from New York, you can just take a plane. I was telling my friend, I was in Ghana and Sierra Leone in July, August, and we had breakfast in New York. We had lunch in London, and then we had dinner in Sierra Leone. So, you had all your meals in 3 continents. That's how fast it is, but you never look at it. And when an African or a Caribbean comes into this community, who do they have sex with? You don't have to go far. Right. Some of them are married, but if they want to go out, they go out in the African American community, they go out in the white population. There is no boundary. You think that you don't want to deal with them, but they are dealing with everybody. So you cannot segregate that, because human beings are human beings wherever we go. So that's what it is. You cannot stop it. And that's why we need to pay special attention to everybody. We are all special. Don't say because I have a different accent from you, well, there is a reason. A brother, a sister, everybody has different accents, so we can distinguish each other. Sex does not. Once you fall in love, it goes. So definitely, we have to respect each other. And don't forget again the problems, underemployment. A lot of African American or blacks are underemployed. So when you go out there, you cannot feed your child. That's your priority. If you cannot take care of your family, what do? You go out there to go look for money, which and ever way. And that's why it comes to sex trade. And people say, oh my God, if they can only stop. Well, if you can feed them, then they're going to stop. Who wants to go out and involve in sex for money? Nobody wants to do that. But if I don't have a job, I'm not educated, I need to feed my family, nobody's helping me, and the welfare system has really changed a lot. So people have to pull themselves by the boot. And the easiest way people do, go out there, sell drugs, or go out there and sell their body. So before you tell them to stop, find something to feel that. Find something to, educate them or empower them So those are some of the issues that we have to deal with every day. You know, before you condemn somebody, think about, do I have something to offer them?
Interesting. Thank you very much. I was hoping Mr. Williams could perhaps talk about, perhaps getting back to the idea of silence or stigma, the impact of what some may call down low, men having sex with men, whatever term we would like to use. If you could speak to that and the impact of that on the spread of AIDS and HIV in the Black community, and perhaps compare that to the impact of straight Black men with multiple partners. I'm sorry, that sounds like an essay question. I apologize. Anywhere within there you'd like to go.
I'm glad that's your question.
Down low. Down low. That's a lot. There's been much discussion about down low lately. But if we just break it down, I think it plays into what we've been talking about, the silence. And I think that if people could talk about sex, if men could talk about sex, or even we talk about just homosexuality. And I think that what we're finding is that men don't want to identify, especially African American men, don't want to identify themselves as gay or bisexual. So they have these partners, or they have sex with other men. So, I think part of it, a lot of it is probably the silence, the shame. I don't want to talk about it. I don't want to be identified as a gay male or bisexual male. So, but I enjoy having sex with another man. And so they go out there, and then so they come back and they infect their partners, either other men or even women. And so again, I think that goes back to the silence. And so if we could have dialogue about sex, if we could have dialogue about HIV and make it where it's okay to talk about. But right now, I don't think that there's a place that many who practice that feel that it's comfortable or it's okay for them to actually talk about.
Would anybody else like to comment on the issue of down low and how that might kind of impact the spread of AIDS to the larger Black community?
Well, I just want to say that within the prison system, you have a lot of what you call situational homosexuality going on, where these men will participate in homosexual behavior within the prison walls, but as soon as they walk out, they consider themselves to be heterosexuals and go right back to their wives and their girlfriends. And so, everybody's talking about, condoms and all that. Well, condoms certainly are not an option in Texas prisons. I was born and raised here, so I freely say that we're the good old boy state. And we need to change that. We need to look at what we can do to help people in other ways. I mean, right now I just started a pilot program. PREA is starting now. And PREA, if you don't know what that means, is Prison Rape Elimination Act. The federal government mandated that all states have a prevention program for prison rape because, Texas, we like the silence is about sex does not happen in prison. Let me assure you that it does, amongst men and women, okay? And whereas the men are concerned, it's more of a power and control thing, where it's all here, women in general rule from here and men rule from here. So within the women's system, they create all these emotional binds and bounds and stuff goes on in there. And so things are spread within that population. That's a segregated population, if you'd like to say, But I've had guys tell me that, they have used sandwich bags for condoms in prison. You know what I mean? It's like, and it's kind of like out here we're saying abstinence, abstinence, abstinence. Well, yes, I truly believe that is the only thing that is 100% for sure. Is it the reality? No. So we have to do something. In some states, they do give prisoners condoms. Okay, now they're just saying you're advocating sex or whatever, but where do you draw the line so that we can stop this epidemic from continuing its path? It's like this never-ending hurricane across our whole country, not just the Gulf Coast. And so what can we do to stop it is the prevention and the education and I don't know. I just speak that, in these prisons, these people are coming out to your communities, and I want everybody to be aware that they exist and that they're coming. And they get out every day in mass numbers.
I wanted to add to the how do we deal with the issue of the down low kind of behavior and kind of look at it from three perspectives. One is down low behavior has always existed. Mm-hmm. It's not new, so let's say that first. It's become popular, and it's not only black. It's just become popular with J.L. King, and I've been on panels with him around the country. So I wanted to just kind of get that out there because some people pretend that it's already, that's just start happening. But if you go back to and you study the history of sex and sexuality, you will find in the Roman and Greek and Grecian, all of that, it was normative behavior. So because we're shocked, by it. I think the two perspectives that I think for the African American community that we have to address down low behavior is from, as a community, again, you cannot treat, cure, prevent anything you do not acknowledge. That's the first step. So acknowledgement is number one. And then the second thing is, so as a community, we have to acknowledge it to be able to address it. But the second thing is that the men who participate in the behavior have a responsibility to tell their partners and come forward with that. Again, we have to create a safe place for that to happen. So that's easier said than done. But I think, so if the men would be able to say, these are the feelings that I have, this is who I am, it's okay, but I need to be able to tell somebody that, and I need to be able to live that type of lifestyle. But I think also as African American women, with those of us who are suffering the most in terms of the new infections of HIV, we also have to be honest with ourselves. We have to begin to retrain our thinking and not accept a person, a man, at any cost. We have to not be willing to acquiesce and bargain our personal protection just to have a partner, because we're socialized that if we don't have a partner, we're not a whole woman. So we're willing to bargain that for just to have a relationship. As African American women, we know what we see, we know what we feel. That's, forgive me, spirit speaking to you that something is different. So we have to begin to acknowledge that if that partner that we're dealing with or that we have a relationship with, if we think something, if we feel something, then we have to be able to go with that and say, hey, listen, we need to talk about this because you and I are not having sex, so you got to be having sex with somebody. Okay, so, but again, you have to be able to confront that. You have to, and it's doesn't have to be confrontational. It just has to be relational. We have to be able to say to our partner, these are some things that I'm noticing. And I just want to know, have you ever been with a man? Do you have desires to be with a man? If so, just tell me. That's all I want you to do, is to say that to me so that I then have a choice. Because when you don't say that to me, you take away my choices. And that's really what's happening, I think. And I think it's twofold. So again, personal behavior, personal responsibility, because we can't not give people personal responsibility, because if we don't give people personal responsibility, then we do have apathy. But also as a community, we have to embrace the concept that, if you spot it, you got it. And so you have to be able to talk about that.
Thank you. I'd like to give Mr. Williams a chance to follow up. I assume you had something to say too.
Okay. And I guess I just wanted to say what you were saying as far as, you were saying the men take responsibility, but I think women need to take responsibility as well. But I think that you touched on that as far as to be able to ask their partners, like you were saying, and it kind of segues into condom use. And so it's that if I'm having sex with you, I feel good, from a female standpoint, I feel good about myself to say that I'm not going to lay down with you unless you have a condom. And so, I think that we all need to play a part in that, not just the men, but the women as well.
Thank you.
Can I just add something on it? I've had, when you walk out in the community, in jails and everywhere, you hear quite a bit. If you want to have a baby, you have sex with a woman. If you want to have fun, you have sex with a man. These are statements that, you get to hear sometimes. And one thing, like she said, you have to know your partner. Most of the time we just easily give up. And maybe because of a lot of reasons, because we feel kind of helpless, especially women, we don't negotiate, our own sexual behaviors. It's more like, okay, I depend on a man, I'm supposed to be married. So whatever my husband tells me, I'm just gonna go with that. I've seen people when I worked in the clinical setting come in there and they have all kinds of problems with anus, and they say, oh, well, I didn't tell the clinician, but I really had sex, and well, how they put it in my butt. And if a man, I tell them, is frequently asking you to have anal sex, you need to really discuss with them what is going on. Because they may be having another experience also. But as women, and not having power, most of the time we don't. And even when they come to the clinic and they have such problems, they're still hiding it, not even going out and telling the clinician. If you don't tell them what your problem is, nobody's going to help you. But until we start talking to each other, most of the time people say, well, you don't talk about sex, you just get it anyway. I just do it. You need to discuss, and please leave the light on. Because if you don't know what you're getting, don't get it. You have to be willing to look at what you are getting. So, those are things that we really need to, and don't think that, well, if I don't do it, I'm not going to have my food today. Try to talk to other social workers. People will tell you where to go to get your light bills taken care of, where to get your rent paid. There are so many agencies who can help you too with your food and whatever. So don't get short. Don't let somebody shortchange you, because it's a matter of today. You don't know. You do it today, you may get infected today. So don't cut yourself, especially the young people. Don't think that you have to depend on people, for sex to have your next, meal. It's not like that. You can go out there and talk to somebody. Be open. Try to discuss your problems. And there is somebody out there who is going to be willing to help you. Don't shortchange yourself.
Thank you.
I guess one last thing I wanted to say is communication, and not be afraid to communicate with your partner.
Absolutely. Thank
you.
Can
I just say, I'm sorry, I'm just jumping at the bit here, but I just want to say this too, especially I think this is for not just for women, but you would agree that it's for people in general. When a person is not willing to discuss sexuality or their sexuality with you and sex with you, and they try to become aggressive, because this is what I get told by young girls a lot of times when I'm working with them, is that, well, when I try to bring up the issue of a condom with him, he jumps kind of, in my face, or he gets a bad attitude about it, or, he becomes not necessarily aggressive, but he shuts down, or he said, he gets mad at me, If a person is trying to deny you the right to use a condom, and this is what we need to then that person is trying to control you. And that is where you have to say, okay, I have to take back my control, because I need to be responsible, and I want to be responsible for myself. And I think, again, sometimes it's hard to do that as an adult, because we've already, we're 40 and we kind of learned our ways. But if we can get to the younger generation, then we can start to socialize them differently than the way we were socialized. So they would feel more empowered to be able to negotiate better, to be able to say, hey, if you don't want to use a condom, then we, perhaps we don't need to be having, this kind of, relationship. Maybe we could just go out on a date and we don't have anything else going on.
Thank you. Another question I'd like to ask, and I think this could be either towards Dr. Lichtenstein or Dr. Foreman, relating to women in a sense, the availability of partners. So I'd like to ask people to discuss the following statement that comes from Gail Wyatt, who's the Associate Director of the AIDS Institute at the University of California, Los Angeles. And she states, African American women are the only group in the United States where there are far fewer men than women. The availability of a partner who shares the same values is much less likely. The women are more likely to be educated than their partners. They are more likely to be employed. How might these factors relate to, in a sense, power and relationships? Perhaps Dr. Lichtenstein could start with that.
Okay. When I was listening to everybody saying, you've got to tell your man he's got to do the right thing, I think it's incredibly difficult, based on my research and certainly in the literature, for African American women to insist that a man does the right thing. He has control because he has more status. There are fewer of men. They have more status because there are fewer of them. They have more status anyway, certainly in the communities that I'm in. I just don't think it's realistic to expect women to insist on a man wearing a condom. There is a huge discourse around condoms that's all negative, for all sorts of reasons. There's the church that says condoms, you shouldn't use condoms because you should be abstinent or monogamous. That's not practical in the sort of communities that I'm in. There are masculinity issues around condoms. Women, by virtue of being women, cannot insist on men using condoms. You just can't do that. And until we have something like a microbicide for women that you can use without having to, say something to the men, I don't think we're going to get very far with prevention. The other thing on the sex ratio imbalance, in the communities that I'm in, if you have men in jail or in prison, or if they're dead, or if they're considered not desirable because they don't have a job and they don't have many prospects, then the number of available men is very few. And those men know it, and those men have a great deal of status. And those men get status not only by the fact that they, say, have a desirable job and it's seen as desirable, but they get status by having lots of women. That's a marker of status. I don't know how you can deal with that without actually confronting it and saying, well, this is the fact. This is what's on the ground. It's not just, saying to your man, you need to behave, because, everything that is around what is said about women in the AIDS epidemic is, we've got to be the ones who keep the moral high ground. Well, I don't think that's fair. I don't think it's practical. I think we need to think of other ways. Maybe a really good thing to do would be to try and get men not to go into prison, or get them out of prison. Why are they going to prison? Why are there so many there in the first place? Let's be activists for that, not to have men going to prison. So there are more men around, or that they are more mainstreamed instead of in, say, informal economies, say, selling drugs, which is another source of status and, access to women. Mm-hmm. I think these are very difficult issues, but I think they're the ones that need to really, really confronted.
Let me add to that, and I think I certainly don't want to be misrepresented or misinterpreted. I hope that I've made it perfectly clear that I think addressing all of these issues, we have to address from the crib to the tomb. Mm-hmm. Because there are so many socio-economic, all kinds of issues that we have to address to truly do what we need to do, to really mitigate, minimize, totally eradicate the issue of HIV. I think as it relates to your question, which was about the availability of men and whether or not that's a true statement from my colleague, Dr. Wyatt, who I've worked with as well. And I think the crux of it is not necessarily, condom use is only one aspect of it. I'm not even talking about when you get to the condom. The condom, that's just a tool we have. What I'm speaking to is just from a sociological viewpoint, whether it be male or female, the responsibility, the part that men can play in that, as well as the part that women can play in that. And because my research is primarily among the empowerment of African American women, I speak specifically for that. I really believe, and I'm so glad, that there should be men speaking to the issue of men, because oftentimes, because of that power struggle, sometimes men won't listen to women. So that's why we need more people like Dr. Williams to do that. But as it relates to the question that you asked about the availability, I think that's partially true because we know the numbers. We know the statistics of the number of African American men incarcerated and whatever. But I think there's another aspect of that that's not true, because in the African American community, oftentimes African American women, as they become more educated, we are less likely to see the availability of men who are less educated than us. And so we don't give those men an opportunity. Mm-hmm. So that's really a more correct answer to that question. There are men out there, but they may not be a PhD. Right. They may be the guy that's, coming by and delivering your mail, who is a perfectly good partner. But because of the way we're socialized, again, it goes back to how we're raised as girls and as young men, that if you don't bring the same thing to the table as the partner does, then you're not a suitable mate. And so that's why I said it's partially true, because we know the numbers of people incarcerated or whatever. But the other part of that is that we have to start to look at what is a suitable partner, husband, a mate for us in a different viewpoint, and not required that he has that. And sure, it's not. It sounds easy, but believe me, I think we all on this panel and the other people in the audience know it's not that easy. We're not even trying to present the picture that it's that easy. We know that there's an imbalance of power. If you read any of the work of Gina Wingood and any of those people who study the imbalance of power in African American relationships, you will know that yes, as Judith mentioned, there is that imbalance of if you feel like you have to depend on this person for your status, for your rent, for your whatever, yes, you're more likely to acquiesce. What I'm saying is that we have to start before that and teach, create a new norm where that is not the power, that is no longer the imbalance. And I believe that is doable. I think also, and I believe that Black women can do that African American women can. You cannot, just by virtue of logistics and biology, make a man wear a condom, but you can be in control of your body and not allow that person to penetrate you without one.
Can I just make a
does everybody, do you get what I'm saying?
I do.
Okay. Can I just make a small response to that? And I have no problem with that, but I think we need to look at the populations who do get infected. We need to look at, for example, women who are in relationships where there's a lot of domestic violence. They're much more likely to get infected than other women. It's not just all women or African American women who are at risk. It's not true. There are certain populations, like being extremely poor.
Sure.
This is where these real imbalances pay out. Women who have educational deficits, intellectual deficits, who are sort of somehow disadvantaged in all sorts of ways in life. These are the ones I see who become infected.
Yeah. You're quite right, because as you walk in the community, those are the same women you're going to see every day going through, because they don't have the will, they don't have the power, they don't have the education, so somebody can just come and twist them anyhow. But one time I was talking with one of my colleagues, Amanda, and she brought it up like, Judith, some of these things we have learned from our mothers, our aunts, people in our community, that I even saw that with my mom. I was talking to one of my friends yesterday. I said, God, I try so hard not to take the things that my mom took, from my dad. Because I saw my dad bring a woman in the house and my mom is right there. No respect. But that's the custom. That's what was accepted. And nobody would tell them that it is wrong. And all she did was she would cook and warm water for him, and he takes bath, and he knows that this man, her husband, was in the room, slept with this woman. But it was accepted. Although she didn't like it, she hated it. And I told my mom, I keep thinking, I said, well, when my dad died, I know one thing my mom really regretted. She never had a man by herself. She was legally married to him. They went to church and got married. But he had 5 other women that she had to share with. And sometimes we think that because it's a culture, we see auntie, whoever did it in the past, is okay. But we, the ones now who have our children, it comes back to the empowerment that you talked about. We have to tell our children, you don't have to take what to go through what I've gone through. So it starts in the home. We have to educate the ones who are having the children now that this is what it is. You need to know how you can get HIV. You don't have to depend on somebody for your livelihood, and then move on from there. My daughter is 28. She graduated, and I've been behind her. I said, when are you going to get married? And she looked at me and said, I'm not even thinking about that, because I'm not going to marry any man I haven't dated. So you have to, by your own standard, prepare your offspring that, hey, I've gone through this. Okay, it's gone, it's wrong. This is where I am, and this is where you need to go. And you have to walk with them, because everybody needs a little bit of push and somebody who they can go back and talk to. And they may not talk to you because you're the mother, but let us prepare that environment wherein my daughter can go and talk to my aunt, to my sister or aunt or somebody who is trusted in the family. Because sometimes, they are fighting with us and they are rebelling. So we as adults now need to set that up, that they can have somebody that they can depend on to go and talk to. And a lot of our children don't have that. If they don't talk to us and we don't have the tools to educate them, because we ourselves are lacking, that structure and information. So how are you going to tell your daughter how to protect themselves when you don't even talk about sex to them and you're not even comfortable to discuss sexuality?
That's a very important point. And I think this is actually a really good time to open dialogue to the floor. So I think we're kind of getting into an interesting spark here. Yes.
Listening, I think we're the soldiers of the army that I do outreach work. I have to go out to communities where people are shooting guns and kids on the corner, they get off a bus and selling drugs and having sex. They're selling drugs and having sex, but we're sometimes we have grants and interventions that say, test 2,700, talk to each one of them for 30 minutes, and draw their blood. That's not realistic. You're not arming us with enough time. You're not educating us enough. You're giving us drive-by education. And we're not being paid a whole lot. And we know the most effective times are in the middle of the night. So imagine me going out into a high-crime area, and I may have kids and a family to take care of. But we get burnt out. We leave, we stay in there 5 years or so, and then we run away because we're tired, and we're worried about have I gotten my 2,700? Have I tested my 800? Have I sat and talked and made a difference in that community? We're putting too many programs into one for too few people to go out and change the norms. We have to go out every day. We can't stay here too long. We have to go over here because we need to be over there. You need to be an hour here, 45 minutes there. So we're the army out there, but we're not armed with what we need to change the norms, because they're talking to me in the middle of the night. The guy that's sleeping with a man so he can get his drugs, but his girlfriend across town, they're talking to me. But I need to be there long enough. I need to be there 6 months to 9 months. You need to rent me an apartment and put a staff there in that area and let us stay there 9 months and do some education and change the norms. The programs don't always fit the giant that we're trying to fight.
Right. It sounds as if what we're talking about here is, in a sense, the connection of resources to the community. And perhaps it might be worth talking about, in a sense, resources in terms of the frontline educators as opposed to the community at large and what everyday people can do.
Right, and I myself, which they don't tell us to address telling men how to take care of women. I just take it upon myself to let men know you are infecting women. I've had black guys say, I'm gonna start sleeping with white girls because all the black girls are infected. We're infecting them, but no, that's not in our curriculum for us to talk to them about. You have to, you as an educator, you have to be smart enough to go and say, it's up to us to take care of them. And then for me to sit up and talk to a woman about a down-low brother and tell her she can't call him a faggot, a punk, or queer, and ask him if he's one, and expect him to tell the truth. And a lot of times when men go into prison, they're already bisexual. You always have to go to prison and come out bisexual. Men are bisexual going into prison. So what about the ones that never go to jail and stay at home? And I don't hear anyone addressing the millionaires that are Rockets, that are NBA, and we keep saying it's not a gay disease anymore, but I always come back to you sleep with one man, but no, you slept with 300 women while you were going around the country playing basketball. So it's really we have to talk to everybody about everything and all our partners, but you have to arm us that are gonna come in contact. I educate right off of a strip where male prostitutes are. They're honest with me. But sometimes I look at the watch because I need to go out because I got to go test 25 people and I can't talk to you when I need to stay here. Leave me there for 9 months to maybe change some of the norms.
Thank you very much. That's an excellent point. I noticed there's a woman in the back with the green down there. Thank you.
My name is Donna Jones, and I came in late, so I apologize. But I just heard the end of what the young lady up there in the blue was saying, and I totally agree with you. And so I just wanted to let you know that there are some programs out there that address that problem. And I work for one called the Sister Project. And it's for African American females 18 and older, and we offer 5 sessions. So I'm an HIV educator also, but this is a 5-session group that we offer. And it's 2 hours each time, and we offer incentives at the end. And so I hope I can leave some information about it, because it was put together to address the problems that you're talking about. And one of the things we talk about is self-esteem. And that's obviously a base issue that we have to deal with. And I hope that I can leave some of this information with you because it's something free that we do, and I'm available, and I'd love to talk more about that.
Excellent. Thank you very much. Thank you. And there's a young lady in the white and orange in the middle.
I'm Marissa Eubanks. I'm a student here at Rice University. And you were talking a lot about educating women, helping them to change their behaviors. But just as a previous panelist had said, you have 13-year-old women having children, and you have 17-year-old women having multiple children. So how do you educate them? How do you kind of change that? Because they're not going to really be able to reach out to their children and change it because they're developing themselves at 13 years old. So how do you see that dynamic in the African-American community in changing AIDS in the future?
Well, you know, I hate the word behavior change, to tell you the truth, because I'm 50 years old. You know how long it took me to get to this point that I'm thinking now? It took me 50 years. If you're trying to impact my behavior now, probably it's going to take 100 years to do that. So that's why I like behavior modification. We have to work slowly with people. You met them here. Who gave you the authority that you know what you are even talking about sometimes? Because sometimes, you know, as counselors or health educators, we think that we know so much. I can just walk up to you and spit out whatever I have been fed with. You need to be more sincere and listen to the person and listen to what is interested, you know, what their problem is right there and then. When I worked for the city of Houston, probably I must have been the most arrogant counselor working there, but nobody checked me because I kept getting people coming back to me. Because I have a curriculum that I go by, and I have a room where I sit, and it's just you and me. I'm going to first ask you what your problem is today. It may be food, you're hungry, it may be you need bus tokens to get out. We're going to deal with that before we move on to HIV. You know, I'm sorry. That's how I deal. And we as counselors, we have to look at people and take their situations one at a time. You sit in front of me, it's you and me. You know, let's talk. What is leading you into this kind of behaviors? Or what brought you here today? It may be you came to the STD clinic because you have gonorrhea, but that's not really, that's just an after fact because you're suffering, that's why you came. There is something that is leading you. And if I keep seeing you every day, coming from one jail to the other, I see the same people, I sit down and talk with them. Why are you doing that? And some of them will tell you, oh, you know, I had one client who told me, well, Miss Judy, I keep coming here because, you know, I can't read and write. When I go out in the street and see people walking with briefcase, I get angry and I jump them because that's how he's going to make money. Well, let's talk about, okay, you are not educated. What you can do in this jail, you can go and volunteer and start being a cook, learning how to cook. So when you get out of jail, you can go apply for a job and say, I'm a cook. You know, we have to deal with people and make them think whatever is making them, you know, go back so we can stop reducing, you know, them coming back. So with the children, okay, you know they have had so many, okay, 5, 6, you are 24 years old, you already have 5 children. Well, you know, why, sister, let's talk. Why are you having children, you know, this often? Don't you know that it's really affecting your system too? Let them see what is in there for them. Because once they start seeing the negative part of it, that they can space their children a little bit and take care of go back to school and learn so that you can be able to take care of your children, you know, because they are suffering, because you don't have a job, you don't have education. Let's talk about those things. It always has to be their interest, because once they see their interest, then they're going to work with you. But if I don't see anything in me, I'm just seeing what you are trying to throw out at me, and they are very resentful, and you will know.
Thank you. Would anybody else like to respond to that? Okay. All right, okay. I'm sorry, we can move around, we'll move over here and then I'll get to you guys.
Hi, my name is Crystal Obi and I'm a student at Rice University. There's been a lot of talk among panel members about the breakdown in communication between patient and doctor, talking to school children, talking to college students. But I would like to say that people do talk to us about sex. The mass media really does talk to us about sex on a daily basis. We hear it in our music, we watch TV, but the message that they're sending us isn't really congruent with the message that you guys are talking about today. And I would just like to ask, I mean, it's gotten to the point where it is normal for me to see a woman in a scantily clad bathing suit dancing on a rapper, but it's not normal for me, and it's uncomfortable for me to see a middle-aged couple showing each other affection on The Cosby Show. It actually is, and I didn't realize that till recently. So I would just like to say, the programs that are coming out now that use music and television to try to reach people about the messages you're delivering, do you see them as particularly effective, or do you think the overall message is so anti-180, the message that you're giving, that you can't even use those outlets, or do you think those are effective resources?
Let me say, I think that some of the campaigns that have come out, like Wrap It Up and other campaigns that CDC and ONDCP and other agencies have put together are effective. They are designed by health educators like ourselves. So it's not, an entertainment group designing that. The entertainment group is a medium, but health educators and health promoters are the people who are the professionals behind it. So some of those programs work and are effective. But I would say that other things that you're seeing, where you see a lot of explicit sex, like the rap videos and sex that you see on sitcoms and things like that, remember that the media shows sex purely for entertainment and secondarily for education, if you can get a little bit of education, but primarily their goal is to entertain. So I think people have to really know that that's what the TV and print and those kinds of things are for entertainment. I think it kind of goes with what everybody has said, and that is meeting people where they are. So whatever medium you can use to get the message across, I think I'm an advocate for it all. I think whatever works in the community that you're trying to impact is what you have to use. And even though you have a curriculum that you go by for, if you're a certified HIV counselor or tester, you have to do certain things. We all learned that. But if you're in a room with a person and they're telling you, this is my issue today, I want to use a condom, but my partner has threatened me or said that they're going to leave me or whatever, then that has to switch up for that moment in time. So I think any form of media you can use, any strategy, as long as the information is there and you're able to impact that person, then I think it's all good. All of the avenues are good.
Yeah, I just want to say that in America, I think we're behind the times as far as using the media. In that I went, the first 2 weeks of September, I went to Germany to see my brother who lives there. And I was sitting there watching TV. I didn't understand a word they were saying, but we're addicted to TV. We'll just watch the noise box. And this commercial came on, and it was about HIV and AIDS. And they had to pick me up off the floor. Basically, this commercial had these teenagers at this party, and they were in red T-shirts. Some were in red T-shirts that said HIV positive. Some were in red T-shirts that said AIDS. Some were in no T-shirts at all. They were just in normal clothes. And as this commercial progressed, these people went throughout this party. You had an incident where a young man having an HIV positive T-shirt was getting in bed with a young woman who did not have a T-shirt on, and you saw him put the condom on the nightstand, and that's where it was left. Towards the end of the commercial, and this was a large party of teenagers, everybody that had an AIDS T-shirt on would turn into ashes and fall to the floor and disappear. And so by the end of the commercial, you had like 3 teenagers left at this party. And I thought, my whole life here in America, I've had to watch commercials about tampons and women's products. And not that I'm offended by it, but I don't see why that's okay, but not having a commercial like I saw in Germany on TV in America, because kids watch TV. Young people, everybody watches TV, and we can't do that. So I think that we need to use it. And I love that you said about, seeing the scantily clad women. The message that we send to women in general are just horrific in our country, and so it's just going to keep, it's like the Berlin Wall came down, these walls will come down if we keep pushing.
Thank you. I had a few hands in the middle. Yes. We can get a...
We got a mic for you.
We have an AIDS ministry. We have since like about 88 or something like that. And it's just something that you can turn around and hear things that are so appalling. When you said that there were no condoms in the prisons, it was like, I can't believe it. I mean, it's just so many things that that's going on and you don't even know about it. And it just seems appalling that you would have all of these prisons in Texas and no condoms.
But they're not supposed to have sex, you know that. So, why protect them?
Yeah, yeah.
There's some sex in prison. Let me give you a little scenario that happened in Africa. You know, you see all these wars going out there, and the armies that are sent there, United Nations peacekeeping forces, go out there, and it was a joke. They gave them, their budget was $1 million for everybody around the world for condoms, and they were only allowed 1 condom a day. So, you know, I was joking. I said, who do you hate so much to use that 1 condom on? Because, you know, a lot of them are having sex 5-6 times a day, but they are only supplied with 1 condom.
I just want to say that just this past year, I visited South Africa, and I was very surprised that in a lot of the bathrooms there were condoms. As a matter of fact, I brought some home so I could show it to the people in the AIDS ministry. Also, they had, it was an advertisement in the paper, and I can't think of the name of the animal that it was, but it was like a dinosaur, some kind of bad animal, and had a picture of that animal on top of a woman and saying that they were AIDS. I say, wow, can you think of something like that being in the paper here in America?
You know, when
they do advertise. I know that AIDS is really bad there, but they do talk about it publicly.
And on social marketing, I found it so interesting. When I went to Zambia, they gave me a pack of condoms. It's a little box. It has 3 condoms in there. You know, I mean, why do they have 3 condoms in there? You know what it was? And they told me, you know, because some people say, okay, this one is too small for me, this one is too big. But they had 3 different sizes in there. So when you take that little box of condom with 3 sizes, there is going to be one that is going to fit for you. So I found that it was so interesting that they market their condoms that way. So sometimes when you go to the different countries, you learn quite a bit. And then nobody has excuse. At least you have one that can fit for you. And if you cannot, you can pass it on to somebody else.
Thank you. I have a hand in the middle there, the young lady in the pink.
I just had a question and a comment. I do think that what Ms. Foreman was saying about the media and what she said, I don't think that the children know that the sex is for entertainment. I do think they think it's education. And what we present, and because I'm a high school counselor, and I work with 9th and 10th graders, and what they see is, oh, okay, I have to be with a guy who's tough and who's rough and who has tattoos and who has goals in his mouth and who dresses in such a way. And he may have come from prison, and that's a good thing. It's not a bad thing if you've been in jail. That's a good thing if you've been in jail. So it's like, okay, well, he's just got out of jail. Maybe he was having sex with another man, but who knows? So I'm not going to ask him. And I see my mother having sex with different people. And every time I look on the TV, I see that it's okay to have sex with different people. And it's okay if a guy calls you a hoe. And it's okay if a guy says that, oh, you know, you're a tip drill. That's okay. That's acceptable. That's not anything that's unacceptable. And no one is saying it's unacceptable. So it is like, okay, well, yeah, this is what the children are seeing, and this is how they're being educated, because society isn't talking to them and we're not talking to them. So I definitely think, as the gentleman said with the green shirt, you have to talk to everybody about everything. But what I wanted to know is the educators who are going out to the schools and then just talking to people about sex, especially the teenagers or the young adults, were you talking to them about other types of sex? Because they have gotten a message, don't have sex, but what they've heard you say is don't have vaginal sex. So there's like, oh, don't have sex. Oh, okay, so you must mean have oral sex. Or you must mean have anal sex. Because you didn't say that. You just said don't have vaginal sex, use a condom. So I don't have to use a condom when I'm having oral sex. So you must have meant just don't have vaginal sex. So you telling them about the different types of sex and different types of disease you can get from having those types of sex?
So your question is about what type of education that educators are giving, and are they covering things like oral and anal sex?
Yes.
Is
yes.
That
yes.
Okay, excellent. Yes, please.
You know, I just wanted to comment, since we talked about the can you hear me?
Yeah. Okay.
Just wanted to comment about, since we talked about the means of getting these messages out. I think the media and all of these different things that we really talked about here are important. But I'm going to date myself a little bit and say the revolution will not be televised. Okay. This is going to be a battle that, if we're going to win, we're going to win it with hand-to-hand combat. That's right. That means personal responsibility. That means each one teach one. And I think that actually needs to start at home. You know, we talk about which message are people going to listen to, and which message is going to get through? And is it the one from the basketball player? Is it the one from the rapper? Is it the one from the priest or the preacher? Is it the one from the doctor? Probably not. Is it the one from the health educator that's toiling, tirelessly? All of those are very important. But at the end of the day, the person that's probably influencing you the most is that parent. And, it does sort of go back to that personal responsibility, if you will, and it opens a whole nother can of worms that perhaps is beyond the scope of this particular conversation because it's focused on HIV. But I don't want to let black men off the hook when it comes to the question of their role as fathers. We've talked a lot about women having babies, but they didn't do that by themselves. And so the responsibility comes back to the parent. The responsibility comes back to the home, I should say. And it's very difficult, and I would even argue impossible, for a single black woman to raise a man. It's tough. I mean, who's going to tell him how to be a man? And so the responsibility, I think, in that community, in our community, lies within us. It lies within each one of us, not just here listening to these messages and chiming in when we feel like something struck a chord, but actually walking out of here and in hand-to-hand combat, go tell one. Go tell somebody what you heard here today. If we do that, if each one of us takes that personal responsibility to get the message across, well, then we've got a shot.
All right, thank you very much. Okay, we have time for one more. The young lady in the back has been very patient.
Hi, good afternoon. My name is Joelle. I'm a first-year MBA student at Rice. I want to speak on parents. I think parents presume that their kids are so innocent and they're trying to protect them from something, because it was so amazing to me during the Super Bowl. Janet Jackson's breast was shown. It was like, oh my God. I'm just like, I'm sure they have seen breasts before. When my kid was watching this, I'm like, you're presuming your kid is innocent. Because in terms of the marketing, at least I'm back home in Trinidad, you don't presume innocence. We don't do America. You're not presumed innocent. I'm going to assume that my 5-year-old knows the penises. I'm going to assume it because she probably does. Somebody's speaking to her, the other kids are speaking. So a couple of years ago, which they stopped it because I think they were getting influence, American influence, they took a bunch of girls from a Catholic school. They told them they were going on an outing. And they took them to the AIDS ward in Trinidad. Like, the cases of AIDS weren't that large. So you had a particular wing that was just AIDS patients. And just let them walk around. And they saw like the late stages of AIDS before somebody died, when their whole bodies degenerated or they're thin. And they let them stay there, and the girls are probably crying and stuff like that. And they said that you're traumatizing them. I'm just like, you're never going to forget that, though. Like, seeing that, you're never going to forget that, and the impact that is formed. So those kind of nice, I understand it's probably effective in some communities, wrap it up and stuff like that. But even with disasters, like, everybody kind of, it struck a nerve when people actually saw people were dying in Louisiana. As opposed to people are dying in Louisiana, could you give some money? But when the media turns it on and you really see the dead bodies just covered with plastic bags and stuff like that, it really hits a nerve. So sometimes I agree with what the guy said about the commercials in Germany. It has to be raw to get through. We only remember that. We like graphic films, we like violence, we like Scarface. When you see blood, it's raw, that's what you remember. You don't remember, wrap it up, Free said on BT, wrap it up. They don't remember that. As opposed to, and this presumed innocence. I was a counselor on my campus giving tours or whatever, and the parents will drop their kids off. Because I came to this country by myself, so I didn't have my mom to do all the kind of decorating, and they'll drop them off and they'll decorate their rooms like if they can't do it, and I gotta take care of my baby. And as soon as they leave, the first homecoming on a black campus is just something different. I don't know if you all know that. Homecoming on a black campus is amazing.
If you can. No. I just wanted to kind of give you a chance to kind of finish up because we're going to be running
Okay, I'm sorry, I'm
over.
done.
That's okay. Thank you. Well, I think you bring up an excellent point about the idea of communication and messages and things like that. So, okay, I want to thank everybody for this panel. You're good.
Thank you.